Good morning, everyone. It is 9:15, and we're going to go ahead and get started. We've got a great program today, and we want to make sure that we are respectful of your time. We want to really appreciate the folks who have stayed over on Saturday to come to our program, and greatly appreciate our faculty who has also stayed over. So this is the Fundamentals of MS Care, Part 4. We're going to change gears a little bit. For those of you who have attended the first three, we kind of have a theme for each day. So I'm very excited today that all three of our speakers are nurses. All three of our speakers are on the International Organization of MS Nursing Board. We have a new officer with that group. They bring many years of experience of clinic coordination, working with patients, clinical research trials, and everything like that. So we will have a break after the second lecture. We'll announce that at this time. So I'd like to go ahead and welcome up Tamika McMillan. Tamika will be coming. She's got her own fan group in the back here. I'm waiting for the shakers and everything to come out too, so do not allow me to have to escort you out if need be. No, we are thrilled that y'all are here with her. What I would like each of our speakers to do is to kind of introduce themselves, to give a little bit more details. We'll follow with Sarah, Jeffrey, and we changed things up a little bit this time. We're going to do, our last session is going to be case studies. So Tamika, we're going to have you come on up. Let me get your slides going here. All right, there we go.
So good morning, everyone. Again, thank you for attending the last day. I know most of us prefer to be on the plane going home, but we're here, so thank you all for attending. So my name is Tamika McMillan. I work for the Department of Veteran Affairs Medical Center in East Orange, New Jersey, and I have the pleasure of working on a spinal cord injury unit, and we also are MS Center of Excellence, but we also take care of spinal cord injury, ALS, and MS patients. So my role has been working in the outpatient clinic where I have the pleasure of taking care of all specialties, but I am a MS certified nurse, so that is also one of my passions as well. So I'm going to be coming to you today talking about clinic coordination. So we developed this topic because there was a lot of discussion around new nurses coming into the clinic and how difficult it is to navigate the clinic. And, you know, there's just what we've been hearing from the clinicians is about new clinicians coming into the MS care arena and what tools are already out there, what is being used already, some pearls of wisdom for coordination of care, and that's in pre-clinic, in the clinic, and post-clinic visits. Phone triage, how are other clinics following prescriptions, how the nurses are following prescriptions, what is the current patient flow, how are the visits being scheduled, how are the nurses following labs, especially those needed around infusions and clinic research opportunities, things of that. So we thought that this would be a good topic for us to bring, and I can share some of my knowledge as to how the clinic that I work in coordinate these visits. Also it's important to get things in order and prioritize because we want to decrease wait times. We don't want to waste the patient's time. We want to be prepared for them when they come into our clinic. And what does that take? It takes pre-work, right? So what our agenda is with just the introduction, how do we get organized? What does a pre-clinic visit look like? Who conducts those pre-clinic visits? What happens during the actual clinic visit? And then post-clinic follow-up, what does that look like? And then just some pearls of wisdom from me personally as to how I navigate those different clinic visits. So this is a quote that I like from Les Brown, and he says, "You don't have to be great to get started, but you have to get started to be great." A lot of times we get into our head and we have so many different things in front of us, so many different tasks that we have to tackle, and we're like, well, how am I going to get to Z? But you haven't even thought about A first, right? And prepare, 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 get yourself organized is definitely something that is important. So it will take pre-work and organization. Now, for some, you know, we have some that are the computer era, right? But I am not a stranger to paper. Sometimes I like to get myself organized on paper first, and then I can create my electronic foundation. But that may not be everybody's story, so whatever works for you is fine, but the most important is definitely getting yourself organized, right? Writing it down, starting, you know, creating an agenda. What do I need to do? What are my priorities? And then some might say, well, they're all priorities. Okay, then we have to organize, we have to prioritize our priorities, right? We need to learn how to say, okay, thank you, I acknowledge your request, but I'm gonna put that in the parking lot right now, because the parking lot has a lot of priorities, so I'm gonna get back to that, but acknowledge the request. So we know change is inevitable, so the process should evolve as you're moving through your clinic, right? So we need to find out what works and what doesn't work. Are there any standard operation procedures already in your clinic before you even get there? And if they are, we need to evaluate and assess those operations first. And we can initiate them, we can use them, and then as we go along, if we find that something is not working, we readjust, right? That's what we do as nurses, we readjust. And then we can move accordingly. So standard operation procedures is something that my chief, Dr. Gibson Gill, is big on, because it's like, if we're doing something that's working, why not make it easier for the next person that's going to come behind us? You can just pretty much hand them an operation and they can follow it. And again, if they feel like it works for them, great. And if it doesn't, they can tweak it and make it their own, right? And then it'll be better for the person that comes behind them. So it's important that you establish how you want your clinic to flow, right? So establish a day to do certain things, right? Okay, so if you want to go by weeks, you can go by weeks. If you want to go by days, you can go by days. I go by weeks, right? So depending on what it is, the third week of the month, I'd like to organize myself for the following month of patients that's coming in. Whether that'll be chart reviews, who's coming in, what labs they need, what, if they're due for imaging, if they're due for a nurse visit, and then when they come into the clinic, I already know what I have to do with them. And of course, I'm gonna discuss with them what are their goals for that particular visit, but at least I have an idea of what I have on my agenda, what needs to be done. And of course, you know, share partnership with the patient as well, but at least I have an idea. So this is just a spreadsheet that I have, and I changed it around a little bit, but this is a way that you can get yourself organized. So if you have a patient list, some you can have this electronically, well, this is an Excel spreadsheet, so it is electronic, but it just gives you an idea of what the patient may need, right? And how the next couple of months is gonna go. So depending on your provider as well, right? So if you have multiple providers in your clinic, each provider may need something different, which sometimes poses a challenge, right? Because not every clinician wants an MRI every year, right? So you have to find out what the needs of your clinician is and then base your spreadsheet on that. So this is just something that I had just put up there, so you have, and then it's electronic. So if you program it correctly, and I did this on Google, I am not in an Excel guru, but I went to Google and I figured out, how do you program something for 30 days? How do you program something for 6 months? And when you put the first date in, it calculates the rest, right? And that was very easy for me. So I have my patients, however many patients that I have, okay, fine, this was the visit date. The next visit is gonna be in 30 days. This is their last MRI. This is the next one that they need, blood work, et cetera. And so I think this is a good way to keep myself organized. So I'll bring this up every day, and depending on who I have coming in my clinic, I know what's the next step for them, and then we can go from there. So I thought this was you know, something that I do that has been working for me. So what is a pre-clinic visit? So it says create the patient Excel spreadsheet. So before you even get here, there's pre-work that we have to do that I would encourage you to do to keep yourself organized. You can't go into the pre-clinic visit and you don't know your patient. You haven't looked at their chart. You don't know when the last time that they had blood work done. You don't know when the last MRI was done. You don't know what DMTs they're on. So it's nice to do, it behoove you to do a chart review before the pre-clinic visit, and then you call the patient. If you have a nurse working with you, that's great. A medical assistant, somebody that can actually make the phone calls. They're not calling the patient or doing, as you can see here, a telehealth visit with the patient. As a clinician, they have a questionnaire that they're using. They're asking the patient, tell me what medications you're on. A lot of time we find a lot of discrepancies there because what we have prescribed in the computer is not what they're taking. And so that will take time away from the clinician in the actual clinic visit to do that, right? So they'll already have that information in front of them. They already, have the labs pulled up. So when they start the visit with the patient, the pre-visit is what the medical assistant or the nurse can do before they see the clinician, because we know we don't have an extraordinary amount of time to spend with the patient, right? So when the patient comes, it's nice to be organized to focus on the actual what's important to the patient. What do we need to actually focus on for that visit? I'm going to say I'm a paper girl, y'all. So the chart reviews will tell you what you need to know. Medications they're on will dictate what labs that needs to be ordered and when. And I have here, don't bother yourself with trying to memorize all the different medications and what labs are needed, because that's just, why keep that in your brain when you can use our DMT cheat sheet that Sarah has created for us, that we can just have it on our desk, and we will know if they're on this medication, this is what we should be focusing on. And plenty of resources that you can have up in your office, so don't bother yourself trying to memorize all of that medication. But of course, you have certain patients that are on certain medications that you're going to commit to memory without even trying. And then, again, as I said, it depends on your provider, what their focus is, right? Because you have some providers who want to focus on vitamin D. They want the levels between 30 and 50. They are rigid with, they need an MRI this time. We want the CMP done. They have to have their blood work done before their infusion. We got to check the quantiferin gold, whatever it is. We need to know what the focus of your provider is so that you'll know what to assess in your pre-visit. Using technology, and I'm not sure if you have this in your respective clinics, but at the VA, we use something called clinical video telehealth, CVT, telemedicine, so that we're able to see directly in the patient's home. We're in our office, they're sitting in the comforts of their living room or at their kitchen, and they're just, sitting there, and it's also a way to actually assess their environment as well, right? So you're seeing, and you're just looking all over the place. You're like, okay, the headrest is, if they're in the wheelchair, the headrest is tilted. Boy, the hand control is not working. Their sip and puff is, whatever it is, but you're able to visually assess the patient as well when you're doing this video visit. And it's a little bit, it's personable, right? So you're there, they're comfortable, and then you're able to assess them and do their pre-visit and get all these things, the med reconciliation out of the way. What is their goal for when they see the provider, right? So that the patient already explained what they want to focus on. So then the chart review has been done, the labs are been done, you know what they need, and so now we get to the actual clinic visit. The patient's goals are known, right? The provider can recap the pre-clinic visit. So you had a visit with the nurse, and I understand you want to focus on, you've been having some issues with, this, you've been having issues with that. And because that information is already obtained, that'll cut down on a lot of the talking, and you can focus on your physical assessment, right? Putting hands on the patient, doing your walking test, do whatever you need, because all of the things that would have happened 30 minutes or took 15, 20 minutes discussing, the provider already knows. And I think that makes the patients feel good, where now they're like, okay, so the doctor knows what I need to go over. And when you get there, they're like, okay, wow, this was beneficial. I like that, right? So we can focus on what we need to focus on in that visit. So be prepared and know your patient. give them the results of the chart review, right? So I see that you had labs done 6 months ago, so we're gonna see, we can get those labs done today. Your last MRI was here, we can get that done, or what have you, whatever you need to do. So you wanna also discuss the goals of the next visit. And you want to make sure that you give your patients a return to clinic appointment when they're in clinic. You don't want to have to go and do a whole 60-patient chart review trying to look through to see what patients were seen 3 months ago or when they were last seen. You know how much time that would take to do that? So if you're making sure that you're giving your patients a return to clinic visit when you're seeing them, will save you a lot of time. And then you can go back to the spreadsheet that I showed you because it's already there. You pull it up, you have all of your information in real time, and you know who needs to be seen. So you're expecting to see this 5 patients who I saw on this day at the same, again, at the same time. Also, when you're dealing with, not just MS patients, but patients in general, they're getting older, our population is growing. Sometimes you have cognitive issues, memory issues, so it's important to give visuals. In my opinion, I like to give visuals. This was something that I actually did for my DNP project. It was actually it was a patient infographic for patients with spinal cord injury for them to be able to retain their patient discharge instructions. So you can design these on Canva sometimes, and you have to design these at a 4th grade level because it's more pictorials, and you have the little lungs up here, so it says, oh, something with my lungs, I gotta do something. I'm going to pulmonary, I'm going to respiratory, I'm going somewhere. So sometimes when you wanna have your patients, be held accountable, you can actually give them something like this. I made some that was generic. Some of them were created specifically for a particular veteran or patient, depending on what their needs were. But this is also something that keeps me organized and keeps them, holds them accountable for their own health, right? For what they need to actually get done. I would encourage them to put this on their refrigerator, and loved it. They loved it. So this was something that I also do. So the post-visit. So the post-visit is afterwards. So sometimes we don't always think that it's important to call your patients afterwards. It can just be a phone call. It doesn't have to be a VVC visit, but it could be, right? It could be a virtual visit, and you want to call your patient and, ask them, so is there anything else that you forgot that you want to discuss? Recap the clinic visit. And again, this is going to be something by your medical assistant. This can be done by your nurse. Not necessarily the clinician, because you want the clinician to be able to focus on the patients that's in the clinic that they're seeing, but this can actually be done for them just to go over what was done and ask any follow-up questions that they may need. It's important for our patients to feel valued and that their time is valuable as well. We don't want them to feel like we're wasting their time. So to actually be prepared when they come, recapping the visit, letting them know we heard you. Just want to make sure that you got your appointment for this. You got your labs done, and just to see if you have your appointment that's coming up in whatever day. You'd be surprised the buy-in that you'll get from your patients when you do those things, right? They feel like, oh, my doctor called me after I left, and they feel good. They feel good, and it gives buy-in, and they really believe that you care about them when you do that follow-up. It always, it's like, oh, you just want to check on me to see if I did my homework. Yes, yep, just want to make sure that was done. And it just shows the partnership between the patient and the clinician. So telephone triage is really time-consuming. So I would encourage anybody that's in the clinic, when you have to do telephone triage, if you're the only nurse in the clinic, this is what I do. I have a certain time that I actually answer my phone. So in the morning, I have 2 hours when I'm answering, because when you're in clinic and you have patients coming back and forth and you're seeing patients every 15, 20 minutes, 30, who has time to answer a phone if you're there by yourself? I don't. I really don't. And that phone is busy and it rings. So what I do, it's just in the morning, I come in, I check my voicemail, and then while I'm doing that, I have if my phone is ringing for the first 2 hours, I will answer that, and then I'm also preparing, I'm good at multitasking, and I think probably everybody in here is good at multitasking. So I answer my phone, I check in my voicemails, I'm checking my secure messaging to see if someone sent me a message about a medication refill, and when that time is done, everything else goes to my voicemail, because on my voicemail it tells them, if you are having an emergency, you should call 911. Right? Calling me back-to-back I don't say this in the voicemail, but calling back-to-back 3 times, you are delaying treatment that you could possibly need. So I'm very clear on that. And then during that time, when I'm not answering my phone, I can do my chart reviews, I can get prepared for my patients. I'm ready for them when they come in. Hi, Mr. Jones, how are you? Okay, we met, we spoke last week, or we did a VVC visit last week. This is what the focus is for this visit. Is there anything that I missed that came up after we spoke that you want to focus on today? Oh, no, everything is good. Okay, so we have your labs, we're going to see if we can get your imaging done. One of the things that I would encourage when you are working in a clinic, know your key players and know who your resources are. Make friends. Make friends. Do you know how many times patients have come to my clinic and they have had an appointment for pulmonary, they need to see OTPT, they need to have an ultrasound, because you have to make an appointment for an ultrasound. You can't just walk in for that, but you can walk in for a chest x-ray. When you know the people in those departments and you are friendly, they will help you. They will accommodate you, and it's like so many times I had to call different departments, and I'm like, hey, my patient's here, but he's fasting. Can you please do this ultrasound for me, or what have you? Oh, I'm calling PFTs. They need to have a PFT done. Can I send the patient up? And they're like, sure, because it works both ways, right? It works both ways. So knowing your key players, but back to the telephone triage. I tell my patients as well, they know. Tamika's not gonna call you back. It's gonna be done. So I tell them, if you call me and you leave me a message about a medication refill, if I don't call you, you can count it as done. There's no need for you to call me back 3 times. I promise you it'll be done, and they know that about me. Now, they may not know that about a new clinician in the clinic right off the bat, but that saves them time, that saves you time of checking through 3 voicemails of exactly the same thing, and they know if it's done. If I call you, I have a question and I need to do an assessment. You haven't had this done, and you haven't had this refilled for 6 months, and then I need to find out why. Why are you refilling this and you haven't had it done in 6 months? And it was only a 30-day prescription. But be clear on what you want them to tell you on your voicemail. In that time when the clinic is, when you're in the clinic and you're done with answering your telephone, sometimes they'll bypass you and call another extension, and then you have that person coming to your office telling you, oh, I have Mr. Jones on the phone. Okay, can you talk to him? It's okay to say no. Is it an emergency? I don't know, he just called. Okay, you can send him back to my voicemail. Hopefully it doesn't sound harsh, but sometimes you have to do that because you have to focus to the patients that's in front of you. And if you are getting your time monopolized by someone who just wants to call because they just want to talk to you to tell you, oh, I need a prescription of my vitamin D. You call me 3 times to tell me you need vitamin D. Okay, I'll take care of it, but it's time consuming and it takes away from your time that you need to be focusing on in the clinic. So I wouldn't say be rigid, but be firm. Sometimes you do have to take those phone calls, right? But try not to let it deter you from what's in front of you, because the patients will know that you're seen in clinic, that your mind is not with them. And you don't want them to, she wasn't paying attention to me, or he wasn't paying attention to me. That's not a good place for you to be with, because they're not going to trust you, right? And then in the afternoon, you have your other 2 hours that you're focusing on. You're going to check your voicemails. And I tell them, give them a time frame. Manage expectations, especially if you're the only one. I was the only nurse in my clinic for years, and SEI had over 20-something clinics. Now, all of those clinics, they didn't need a nurse per se, but I still had to manage those clinics. So it was whether who was coming in, what did they need, do I need to, check their vitals, do I need to get them ready, do I need to put them in the bed, whatever. But just to be the only nurse in the clinic, I had to set some boundaries and let people know, okay, I acknowledge what you're asking me to do, and I understand it's a priority to you to get it off your page, but I'm gonna document it and put it in the parking lot. I will get to it, but it's just not gonna be today, okay? So it's okay to do that, and then at the end of the day, check my voicemails again. I'm making sure I return those calls within 24 hours. If it's somebody that I need to call back, and I try to do that, if you're leaving at 4:30, don't check your voicemails at 4 o'clock. You're not leaving at 4:30, exactly. You will not be leaving at 4:30. So I try to check my voicemails between 3 and 3:30. I'll try to start around 3 o'clock, right? But sometimes, depending on if the clinic is still going, you can't, I may not start till 3:30. And we take care of MS patients, and we know it's very hard to get everything done in 30 minutes. So if I have a patient scheduled at 3, once I do my part, clinical reminders, do my assessment, if they need to get an assessment done, and I put them in the bed or do whatever I need to do in the clinic bed, and then I can actually go while the clinician, the doctor, or the nurse practitioner, the clinician is with the patient, I can go and I could, shimmy and get a voicemail checked and try to make a phone call or do something like that. That's where the multitasking come in. And then the rest of the day, everything will get done in the morning. So whatever I check between 3:30 and 4:30, if I can't get that done, that's done in the morning, right? So that's done. I'm checking my voicemails. I'm completing what I wrote down from the evening before, and that's the circle. So that's how my patients know, oh, I don't worry about it. Some of them may see me and say, oh, I left you a message. I know, I took care of it. Oh, it's done. Right? That's the relationship that I've built with them. And so for new nurses, you might not have that, but it will definitely develop. Prescription management, we kind of touched on that a little bit. Just be clear on what you need them to leave you. If you have the luxury of having somebody that's taking your messages for you, that's great, but they need to know what the process is too. Please don't give me a name and a phone number and tell them they said to call you. No. You took that message, I'm gonna need you to call them back and find out what they need. Why are we reinventing the wheel? Why are both of us on the hamster wheels? No. So you need to be clear in whoever's assisting you. Let them know the vision. Let them know what the plan is, and they need to be able to carry it out if they're assisting you, right? I don't need to tell you to do something, and then you don't do it, and I got to go back to do what I told you to do. Why do I need you? So we just have to be very clear on what we need or how we need someone to assist us. What help do we need, especially if they're asking? And that's what they're there for. If you have a team, use the team, right? Use the team. Everybody has a part to play. Patient follow-ups is return to clinic. If you have a scheduler, I always like, if I can, but I do like to sometimes escort my patients right to the scheduler, right? We're gonna walk out together, hand in hand. Visit's over. Everybody's happy. Come on, we're going right here to schedule your next appointment. And again, it holds them accountable too, right? You don't want somebody that's already having issues, 6 months to 9 months, you're like, oh, I gotta check on Mr. Jones. We should have made sure Mr. Jones has a return to clinic appointment before he left the clinic, okay? The results of a chart review, that really shouldn't be there, but you need to know what you're looking for. If you just open a chart and you have no direction, where are you going? You're just gonna be staring at the home screen like, circling your brain. So that's when your partnership with your clinician comes in. What is important for you to know when you see the patient, right? What do you need to know? What's important to you for you to be able to do your jobs? How can I present you with information that's beneficial to you, that's gonna be beneficial to the patient, to maximize the outcomes for the patient so we don't waste their time? So you have to have a partnership with your provider as well. So what am I looking for you? What do you like? What is it that you need? What is it that you prefer? And again, those cheat sheets, I have them posted. Some of them are on my desk. Some of them are hanging right in front of me so I don't forget, right? All right, I know Dr. L likes this. Dr. T likes this. Dr. Joe likes this. right? And unfortunately, they're all not going to practice the same way. Even if they're all MS specialists, they're not going to practice the same way. So we need to know what they prefer. And then the goals of the next visit is a good thing too. So, you know, especially we have time, because we know we can jump ahead. Patients can jump ahead. They're worrying about what's going to happen in 2 years when it's, you know, when it's time for whatever review. And it's like, well, okay, we're not there yet, but let's put that on the agenda. Let's make that a goal for our next visit. This is what we're going to focus on for you the next time, right? It's not due yet, and it's okay to explain to them, well, you're not due for your just hemoglobin A1C. You had it 2 weeks ago. I know it was elevated, and you went really hard in the gym, and you was checking your diet, and you was doing, but it's not time to check it yet. We're gonna make that one of our goals for the next visit. Patients like for you to, in my clinic, they like for you to be upfront with them, be forthcoming, tell them what it is, and they respect you more and they appreciate it too, that you're not just, pulling my leg, just let me know what's going on. And then I can't stress enough that return to clinic visit. If you want to keep yourself organized and not chasing, going back and forth, renewing, looking at the charts, and just doing a full chart review every 3 months, who wants to do that? Do it once and do it correct. Now, you may have a lot of different steps in your chart review, but I cannot stress to you enough how beneficial it will be for you the next time you have to do it. Take some time, shut yourself in. I'm sorry, don't throw eggs at me when I tell you. Sometimes you have to have a working lunch. Sometimes a working lunch is you can't avoid it, right? You can't avoid it. Now, your leadership might not see it, but your patients will benefit from it. I'm not saying doing that every day because that's not self-care, but sometimes you may have to have a working lunch to get stuff done. Also, you may have to you have to do the hard work so it'll be easier later. Do it now. Do it up front. Do those chart reviews. Make your spreadsheets. Know your patient population if you can. If there's any way that you can track your patient load, it's important because I don't know, clinicians, sometimes it's like this 1 week or just 2 weeks of the month, I got 50 patients, but then the first week of the month, I got 7. Why is that? Prepare for that time. Prepare for that time. And I'm speaking to the clinicians, but it's also when the nurse prepares, if she knows, okay, doc, did you realize we got 50, annuals to do the second week in March, but we only have 5 the third and 8 this first week? How can we rework those numbers to make this easier for everybody? And that comes from the chart reviews. That comes from the chart reviews, and they help. They really, really, really do help. And that is all I have for you guys. Any questions? Thank you.
Tamika, thank you so much.
You're welcome.
Yeah, is it coming through? Okay.
Yeah, we can hear you.
I am not a nurse. I'm here listening, so this is kind of personal. Not that my dad had a neurological disease, and at one point when he was still living independently, he lived about 2 counties away. Saw PCP there, urologist there, but came up here to get neurological care and came over there to get that. There was one point where I don't know all the drugs that he was on, but he would get the same prescription from different providers. He would stockpile. He would get into that point. Finally, when he went into a skilled nursing facility, I got the printouts of the medicines that he was taking, and I took a look at 3 diuretics at one time.
Wow.
And I was just like, something has to be changed. So like I appreciate the prescription. I loved your infographic. And working with my dad, he's like, oh, is that my heart medicine? Is that my lung medicine? Is that? So I wonder if on your infographic, if it would be too much to put the medicines on there for when your patients come in, because I don't know what the drug name is that was his diuretic. I didn't know what he was taking for this. I didn't know what he was taking for that. But I absolutely love that. It would have helped me when I started to have to schedule a little bit more for him. But just thank you for all of the tips that you gave here. I think they're absolutely wonderful.
Well, thank you. So the infographic, so that one was actually created for a specific patient. So if you, and I made that on Canva. So that, if that's an issue or something that we're focusing on in the visit, that absolutely can be put up there, keeping in mind they change. So it's just like you put the date up there, and then this needs to be reviewed in so many weeks or whatever, but that definitely can happen. Absolutely. Absolutely. And then I had one that the patient kept forgetting the number to the pharmacy. So I added that, and it was a big pill up there, so they knew this was the number to the pharmacy. So they were able to keep that in mind. And again, you know, I also do, you know, home care, and one of my nurses says to me, you know, the patient still has that infographic on their refrigerator. I'm like, great. The appointments are probably over, but at least the key players that they need to be able to contact were there. So yes, that can definitely happen. Yeah, any other questions? Thank you very much.
I just think this was so timely for Tamika to come and give this talk. One of the things that we hear through the International Organization of MS Nurses is we have new clinicians that come into the arena. They're thrown into the fire. Their clinicians don't orient them to these type things. And you have to, you know, if you're not a type A person that can multitask, you know, you're going to sink. You're not going to swim. And I think that that's one of the things that you can look to us as seasoned MS nurses and mentor. You know, we can do a Zoom visit or something like that. So just know that there are different resources available out there. Thank you very much, Tamika, for that. So we're going to invite Sarah Schaefer up. Sarah is an advanced nurse clinician who works at University of Colorado there in Fort Collins, Colorado. She's got a little bit of a raspy voice. It's that, as someone said, that sexy radio voice. But she has not been out singing karaoke. We have checked that out. There are no videos out there. So, Sarah, come on up. I think this is also another one of those timely lectures that, you know, you've heard throughout this consortium about our MS patients who are aging, and we're a very unhealthy nation with many comorbidities. So this is very timely for this.
Thank you so much, Bev. And yes, I do have a nice raspy voice these days. I apologize. My name's Sarah Schaefer. I've been in MS for about 12 years now. I'm currently working in Fort Collins, Colorado, and so happy to be here, and so happy you guys have stayed out with all the partying last night and everything. So appreciate you being here. All right, these are my disclosures. And the learning objectives today, we're going to talk about comorbidities and their relationships with patients with multiple sclerosis, how different types of comorbidity can potentially affect MS, what some of the MS medications we need to think about with these comorbidities, and what are some of the lifestyle modifications we can educate our patients on, and how that can impact both their MS and their comorbidities. So, I love these word clouds. I just kind of Googled this last year when I was working on this, and it really just shows like all the different things. We aren't going to talk about every single one of these today, but this is all the different things that can potentially be involved with comorbidity, not just with MS, but with all sorts of comorbidities for all different conditions. So the definition of a comorbidity is any additional disease process that is not a complication of the original disease. And specifically with multiple sclerosis, comorbidities can lead to diagnostic delays, increased relapse rates, more disability progression, worse cognition, and worse quality of life, all the things that we don't want to happen. We also know that these patients have higher healthcare utilization, and speaking of the laundry list of medications, they have polypharmacy. And we know that some of these comorbidities can exacerbate some MS symptoms. It can absolutely affect what DMTs we're choosing and some of the other symptom management medications. We know that as people age, comorbidity increases, and it is underrepresented in ethnic and immigrant populations. So this is an interesting graph that I found looking at patients with, in the red is what comorbidities they had at diagnosis and 5 years earlier. So looking across at all these different comorbidities, it's so interesting that 5 years prior, they had less comorbidities, but at the time of diagnosis, they had increased depression, anxiety, lung disease, hypertension, hyperlipidemia, cholesterol, and diabetes. This also is a relationship showing with age. And as we know, as I mentioned before, as we age, we know comorbidities rise with time. So specifically, we see the biggest rises in hypertension, hyperlipidemia, not surprisingly, heart disease, diabetes. But I did find this interesting that depression and anxiety kind of stayed flat, and if anything, kind of peaked in middle age. Excuse me. And then this is showing sex differences in comorbidity and MS. We see in women, they have higher rates of depression, anxiety, and chronic lung disease, and then in men, it's more of the cardiac conditions like hypertension, heart disease, and hyperlipidemia. So again, just things to keep in mind when you're talking with your MS patients. So we know that more than 50% of patients with MS have another chronic health condition. And that can be by chance. That could be by improved detection, meaning that now, because they're coming in to treat their MS, we are monitoring their blood pressure, so we're capturing hypertension now. There may be a genetic connection between the two. It could be as a result of environmental or behavioral risk factors. Could potentially even be from some medication side effects. So I want to briefly discuss to make sure that we understand what modifiable and unmodifiable risk factors are. So modifiable are things that maybe can be prevented or changed with lifestyle behaviors. Unmodifiable are things like our genetics, race, and no matter how hard we try, we can't change our age. And then also consider racial and social disparities. We especially know, I'm sure we've heard throughout this whole conference, is that our ethnical patients are underrepresented in clinical trials, and we know that they have higher comorbidity rates as well. So social determinants of health are also something to really keep in mind when you're assessing your patients and thinking of that your patient holistically. So making sure, we're going to talk about this with each of the cases that we have later on today. We're going to break down these social determinants of health for each individual patient, which can be kind of helpful. But making sure that you understand what their education and background is, what kind of health care access they have, what sort of a neighborhood do they live in, what access do they have to healthy food options, what is their economic stability, are they able to afford, fruits and vegetables versus going to McDonald's, and what is their social and community context, who is their family, who is their support system. So I won't go into super detail on this case study because we've got some great cases later, but this is one of my patients who I diagnosed in 2016. She's 42 years old. Her symptoms, ongoing symptoms, are fatigue, head tremor, bowel and bladder issues. Her comorbidities are migraine. She's a current smoker, half pack a day. She's got depression, anxiety, a little bit of hypertension, high cholesterol, some reflux, and polycystic ovarian syndrome. And since she got COVID in June of 2022, she's had this chronic cough that wouldn't go away. And at one point was affecting that we were really delayed on getting her MRIs, that her cough was so bad. The DMT she's been on, she's currently on ofatumumab, but previously was on Rituxan. Speaking of cough, excuse me. Sorry about that. So diabetes, gosh. We know that there's a 30% increase in prevalence in patients with MS and type 2 diabetes. We know that this can increase risk of vascular changes in the brain, and that can contribute to more cognitive changes down the road. They have an increased risk of peripheral neuropathy, which can affect how patients are feeling numbness and tingling, sensory perception. They have less use. They are underusing their anti-diabetic medications. We know that as glucose levels increase, that may affect patients' EDSS scores. We really want to make sure to use caution in these patients who potentially need steroids for their multiple sclerosis when they have diabetes. I've had a couple patients who we've had to hospitalize so that they can be on insulin drips to really monitor because they're so brittle diabetic. And we want to make sure to use caution with any one of the S1P modulators and the risk of macular edema, and educating your patient on that and making sure if they have diabetes and they're on that medication, they're getting regular eye exams. Cardiovascular things that we think about, clearly hypertension, hyperlipidemia, those are all things that can increase stroke risk and lesion load and reduce brain volume, which again are things that we don't want to overlap with multiple sclerosis. They're at higher risk of heart attacks and strokes. There's an increased risk of DVTs in the progressive patients because they are less active. There is unfortunately lower use of antihypertensive and lipid-lowering medications in the MS population. And specifically looking at the DMTs, we want to make sure to educate and evaluate patients on alemtuzumab to monitor for stroke. Teriflunomide, we want to keep an eye on blood pressure that can be raised in some individuals. Mitoxantrone, which we don't use very often anymore, but I do have a handful of patients who received it in the past, to make sure that you are monitoring even years later for potential for cardiotoxicity. And we probably want to, there is a black box warning on some of the S1P modulators for things like history of heart attack, chest pain, stroke, TIA, heart failure, prolonged QTCs on an EKG. So again, it's really important to get baseline histories on these patients before you're putting them on medications, and or if they're on an antiarrhythmic treatment. Again, really making sure that you know what their home medications are that could potentially be interacting with some of the DMTs we might be looking at. Obesity, there's really a lot of, for kind of the next several cases, or comorbidities, I talk about how a lot of mixed data on their risk in relationship to MS. So there was one large nursing study that showed that patients with a BMI greater than 30 had double the risk of multiple sclerosis, but then there have been some other studies that don't show any relation with adult obesity in relation to MS. We do know that there is an increased risk of, as if any of you attended the pediatrics session earlier today, an increased risk of obesity in developing pediatric MS. And then we know that women who are obese have this kind of low-level persistent systemic inflammation going on that could potentially interact with their MS. And we know that, unfortunately, folks who are obese can have some mobility issues, which can really affect their multiple sclerosis and the importance of getting exercise. Excuse me. Epilepsy. So we know there is an increased risk of epilepsy in the MS population versus the general population. We believe that some of those gray matter lesions can interrupt neuronal circuits, putting them at higher risk for seizures. We think about not only the DMTs, but then we think about some of the epilepsy medications may worsen brain fog or fatigue. So if a patient is coming in talking about that and mentioning that, you may want to look at what other medications they're on that might be contributing to some of those symptoms they're having. We really want to make sure that we avoid dalfampridine for folks who have epilepsy. We know that that can decrease the seizure threshold, and just using caution with some of the interferons in relationship to seizures. Migraines, I definitely have a high percentage of my patients who have MS also have migraines, but again, the studies show a mixed correlation. A few have shown much increased rates, like 2 times more likely. Other studies have shown no correlation. There may be some slight correlation between migraine frequency and relapse rates, but again, the data was not amazing on that. And one study did show higher rates in the Latinx population that have multiple sclerosis have higher rates of migraines. So again, just something to think about when you're looking at that whole patient. Sleep disorders, we know that this is a thing that can absolutely contribute to poor sleep habits, which can contribute to daytime fatigue and cognitive changes. So assessing patients, why aren't they sleeping well at night, and how are they sleeping? Is it restless leg? Have you sent them for a sleep study to evaluate to see if they have sleep apnea, or is it insomnia related to anxiety that they're having because they're afraid that their disease is going to progress and they're not knowing what's going on with that? So making sure that there may be a correlation between restless leg syndrome and MS due to the dopaminergic dysregulation that we see in depending on what area of the brain is demyelinated. And there was not a clear correlation when I looked it up to see if brainstem lesions had a higher rates of central sleep apnea, but if you think of how the mechanism of how that works, that could make sense. Again, talking about looking at those other reasons why they may be sleeping poorly. Cancer rates, this is another one that we have mixed evidence on to see if there's a correlation with MS patients. So we know that individuals with MS who have either breast or colorectal cancer do have higher mortality rates. We know that some of the medications, the DMTs that we use in the clinical trials showed a potential correlation. So with ocrelizumab, breast cancer rates were higher in the clinical trials. S1P modulators, there is a correlation between some skin cancers, so making sure that patients are getting regular skin checks, as we all should be anyways. Cladribine, there is a black box warning on you don't want to potentially really educate your patient or avoid it with someone who has history, current, or high risk of malignancy. Alemtuzumab, we know that there is a correlation between thyroid cancer, melanoma, and other lymphoproliferative cancers. So making sure, again, that you're really keeping a good eye on this and make sure the patients are educated. There was a Swedish study that was published back in 2020, which showed no increased risk of cancer in general for the general MS population, and no increased risk with Rituxan or natalizumab, and showed a borderline increased risk with fingolimod. So again, just another thing, making sure your patients are educated. I know a lot of them are very scared about this, and making sure that they know the most up-to-date data. Autoimmune. We know that other autoimmune conditions have very similar risk factors to multiple sclerosis. So we've got the genetic component, we've got environmental risk factors, and then we've got the immune dysregulation that can relate to all different autoimmune diseases. So we know that there's an increased risk of folks with MS potentially getting diabetes, inflammatory bowel disease, and psoriasis. Interestingly, I've had several different patients come in recently, and it really makes your DMT selection because of the increase. Now patients on inflammatory bowel with IBD and psoriasis are on new different immunomodulating medications, and so making sure that you're not overly working their immune system to cause increased risk of infections. So there is a nice overlap with a few of our DMTs. So dimethyl fumarate, or in the EU, it's called Skilarence, is approved to treat psoriasis. So that's something, if you've got a patient with psoriasis, you could think about one of the fumarates to potentially treat two diseases with one medication. Ozanimod is also approved to treat ulcerative colitis, natalizumab, Crohn's disease. And as we know, rituximab, it works in a lot of different conditions, including rheumatoid arthritis, myasthenia, NMO, and many others. So usually when I've got someone, let's say, who's got ulcerative colitis, I will collaborate with their GI doctor to talk about what medications they're on, what medications we're thinking about for MS, and then so we can make the best safe decisions for those patients. So this is a nice pie chart just showing there's the highest prevalence of type 1 and type 2 diabetes as other autoimmune comorbidities with MS. We also see high rates of rheumatoid arthritis, let's see here, psoriasis, and thyroid disease. So again, just keeping those in mind. So now I'm going to get into some comorbidities that there's some question, are they a symptom of MS, are they a comorbidity, or is it a little bit of combination of the two? We know that both depression and anxiety rates that I'm going to talk about next are much higher in MS than the general population. Some reports showing up to 60% of patients experience that. Again, there's this debate whether it's a symptom or comorbidity. We believe that some of the inflammation going on in the brain that we've been hearing about, this smoldering disease, may be involving some pro-inflammatory cytokines that can affect mood changes in the brain. And then potentially some of the structural changes with demyelination may also affect mood, especially if they are in the frontal lobe. We know that folks who have depression, unfortunately, can have higher physical disability rates because they are less physically active due to the depression, and is something to definitely talk about for lifestyle changes. We know that patients can have more disease progression, poor work productivity and quality of life, and a lot of symptoms, again, can overlap. So patients coming in saying they're more fatigued, they're not sleeping well, and they're having cognitive changes. That may not be entirely due to the MS, but that could be also in relation to their mood changes. Things to keep in mind, again, interferons can increase depression rates, so making sure that you're monitoring for that with those patients. And there was a few studies that showed that potentially fingolimod might decrease depression rates. Anxiety, again, like I mentioned before, is higher in MS than in the general population. Again, this question of symptom versus comorbidity. It's a little more frequent in early diagnosis. I think those unknowns that patients have and can be really frightening and really anxiety producing with new diagnosis. We know that anxiety can, again, lower cognitive function, coexisting with depression, and making sure for both of those patients who have either one or the other that they are potentially established with a psychotherapist and seeing psychiatry to make sure that that is best managed for them as well. Cognitive impairment. So clearly we know that MS can contribute to cognitive impairment, but there has been some studies done that there isn't any increased risk of Alzheimer's or vascular dementia specifically in those who have MS. But we do know that 40 to 70% of patients with MS have cognitive impairments. As I mentioned before, depression and mood changes can lower those processing speeds. So making sure that they get a good neuropsychologic evaluation to help kind of tease out where some of these cognitive issues might be coming from. Fatigue, another question of symptom versus comorbidity. We know that, so whenever a patient of mine comes in expressing difficulty with fatigue and just saying they can't get things done, before I start just throwing them with energy pills or things like that, I really go through and look for secondary causes. So I evaluate their thyroid. There may be potentially some hormones I look for vitamin deficiencies. Again, talking about what other medications are they on? Are they on sedating medications, maybe for sleep, but then are carrying over too much into the day, or they're taking it too late at night, so then they can't get up in the morning? Are they potentially anemic? Are they not sleeping well? How is their diet? Are they eating crappy food? They're probably going to feel like crap. And how are they exercising? We know that there's a clear correlation between exercise and mood. So now we're going to talk about some of the modifiable risk factors. So smoking. This is something I hit on with every single patient who I know is a smoker or a vapor or using chewing tobacco. I'm in Colorado, so we still see that quite a bit up there, unfortunately. Really making sure that we're educating every single visit and asking how patients are doing with that. Because we know that not only increases risk of pulmonary disorders and cancers, it can increase risk of developing and earlier disease progression and transition to progressive MS. So this is so important every single visit to address. We know that clinically isolated syndrome smokers convert faster to MS. Childhood exposure doubles the risk of developing MS. So if you've got that new diagnosis patient who's really worried about, hey, are my kids going to potentially get MS? Hey, maybe if you stop smoking, that's going to potentially decrease the risk of exposure with your kids as well. We know that smoking can disrupt that blood-brain barrier, leading to more atrophy and higher lesion load. And there is some evidence, so again, telling your patients that, hey, if you stop smoking, we may actually potentially see an improvement in how you're doing, and we've seen some decreased risk of EDSS progression. Another modifiable risk factor, I know we're here in Tennessee, which is, I'm sure one or two of us had a little alcohol consumption last night and some caffeine this morning. There are not, unfortunately, too many studies on alcohol, caffeine, and multiple sclerosis, but we do know in general that for anyone moderate alcohol and caffeine intake, there may be some correlation with decreased risk of developing MS. So what is, just a reminder, what is moderate intake? That is 2 drinks or less a day for men, and I don't know why it's unfair for women that we only get 1 drink. But there may be some potential anti-inflammatory properties. You know, we've heard red wine goes on and off the good bad list every few years. There is a potential lowering of EDSS with alcohol, those who consume moderate amounts of alcohol versus none. But we do want to make sure that we're not encouraging our patients to go out and drink alcohol on a regular basis, because we know that that can contribute to depression rates and risk for abuse. So again, so now we're going to jump into prevention. So again, this is something that I bring up with my patients almost every single visit, asking how their diet is. So we know, I'm sure that we've heard throughout the conference, that there is no proven diet for multiple sclerosis. What I recommend is a Mediterranean diet that can be beneficial for brain health, because we know that that reduces the risk of cardiac risks of heart attack and stroke. I really encourage my patients to prepare their own meals at home, use colorful, fresh fruits and vegetables as much as they can. Frozen's also good. Canned is also a good option if they don't have access to that, and can be sometimes less expensive. Encouraging my patients to eat whole grains and avoiding and limiting processed foods and added sugars. You know, I'll tell them, don't kill yourself if you want a couple Oreos when you're going camping, but just not every single day, and things in moderation. But I think this was a nice graphic just showing all the different options. Sometimes I'll encourage patients to, especially, if they, during the summer months, like pick a fresh, if you have an opportunity or they have access to like a farmer's market, go to the farmer's market, pick some cool fresh fruit and vegetable that maybe they've never tried before, and then like build a meal around that. Again, I know not all patients have access to that, and not all patients that's feasible for, but it's something that you can potentially discuss. Exercise, another thing I bring up with my patients, how they're doing on that. We know regular physical exercise can decrease disability progression, lower relapse rates, improve cognitive function, lessen fatigue, and lessen new lesions and atrophy. So, that conversation is really important with patients on what else can I do besides taking my pills? Let's get you moving. Let's get more exercise in. Goals, I will tell my patient, and this is from the American Heart Association on stroke prevention and heart attack prevention, is 30 minutes, 5 to 6 times a week. And clearly not everybody's there, and they're not ready just to jump into that, and I don't want them to injure themselves, so I tell them, work up slowly on that and make that to be your goal. Absolutely utilizing physical therapy is so important to sometimes get that ball rolling with these patients and give them some goals and some guidance on what can be best physical activity for them. Also tell them to do something they enjoy. I don't want this to be punishment. I don't want it to be something that you hate. If you go to the park with your kids and walk with them, or take the dog for a walk, or go for a hike, it doesn't have to be like running on the treadmill every single day. Do something you enjoy. And then being mindful of what physical limitations your patients have and heat intolerance, so I'll educate on that using cooling products and hydration. I tell patients to keep 2 frozen water bottles in their freezer year-round. And then when they're going to be out at like a baseball game, or they're going to be out on a hike, or just out on a warm day, take them with them. They can put them lightly to their neck to help cool down that blood supply to the head. And then they can drink super cold water to also decrease their core temperature if they need that. But there's also so many amazing cooling products out there that patients can get. Either Amazon has a ton of them. I know that there was a vendor in the exhibit hall this week, and the MSAA also has, patients can get free products from them. And then again, just a varying array of swimming, yoga, and aqua aerobics can be really good to help control the body temperature as long as it's not the hot yoga. Uh-oh. I froze. I guess we just have to all do exercise now. I froze. Oh, okay, there we go. I don't know what happened there. Anyways, I also really keep as much open communication with primary care providers to coordinate to make sure that they're getting updated screening, annual screening on diabetes, prediabetes, hypertension, lipid disorders, obesity. Now, these are not screening that I necessarily do myself, but let's say we get their blood pressure when they come in, and they come in for a couple visits and it's been higher than I would like it. I make sure that they coordinate with their PCP, or I might. Luckily, within our system, we have access to a lot of the PCPs in the area, and I can send them a message and say, like, FYI, this has been high a couple different times. We may need to recheck in with them. Also making sure that they're getting their breast cancer screening, their colonoscopies. Again, I don't manage that, but if I see that maybe they haven't gotten it when I'm looking at other imaging, that might be a reminder for them to talk to their PCP about. I don't know why this hates me all of a sudden. That was okay. Oh, I jumped to one. Okay, back to our case study. These are all of the different comorbidities she has. So she's got migraines, smoker we talked about. She's on and off, had a quit date in mind. I'm really hoping, her newest story is she's got a boyfriend who's moving in with her and he hates smoking. So I'm really hoping that that's gonna be the encouragement to get her to stop. Again, depression, anxiety, which is moderately controlled right now. Her hypertension, hyperlipidemia, GERD, and PCOS are doing okay. Her cough has gotten better. We've been able to get her MRIs done, but it's still persistent, and we keep reverting back to this is likely related to your long-term smoking. She does have a high-stress job that we talk about. We talk about her diet and little ways that we can sometimes tweak and improve that. I heard a great story from a nurse colleague who, she is in Utah, I'm in Colorado, and we have a lot of folks that are really bent on their meat and potatoes, as I also love them. But she told this great story about this farmer who was super resistant to making any dietary changes, and so she said, how about this? How about you just add a vegetable to your plate every single day? You don't have to change anything else. Whatever else you want, just add a vegetable every day. He came in 6 months later for his next check. He'd lost 30 pounds. She said, what did you do? He's like, I added the vegetable. That was it. Just by adding that extra to the plate, he was eating less of the other things. And so it was just sometimes just like be creative, and you don't need to make them, because if you tell them to make those big changes, they're probably not going to make it, and they're not going to, just so give them little tidbits to work on, and I thought that was a great one. We talk about her sedentary lifestyle. Again, I'm hoping when the boyfriend moves in, they're going to be physically active, but not necessarily in that way. And then she does have a benign breast mass that her primary care is keeping an eye on. So I have a question for you guys before you get to pick on me. How many of your patients that you can think of have 0 comorbidities? I know that, like they said, 50%. I think it's more than that. I don't know. And one of my patients that have that. And I don't know what that was. That was a comorbidity coming out, yeah. I think, and you know, so much of the topic the past several CMSEs has been talking about smoldering MS and this unmet need of that we can't really treat, and how are potentially some of the comorbidities that our patients are having affecting that smoldering MS, and just really being mindful of that and paying attention to that. All right, anybody have any questions for me? Thank you. My voice made it. Oh, you're so official.
Hi, Jeffrey Hernandez Hernandez from the University of Miami. I have a question for you. Have you had any cases of ocrelizumab colitis or associated colitis?
Thank you for the reminder on that. I meant to put that in my slides. I forgot. No, I have not. I've had a couple patients who I've suspected it maybe a little bit, but then we found out it was more like dietary things that were going on. So no, but it is something that I keep in mind. So that's a new label warning on ocrelizumab is potential for inflammatory colitis. So keeping that in mind if you are having patients who are on that particular medication and having a lot of GI issues. Thank you for that reminder, Jeffrey. Any other questions? Ooh. Oh, good.
You can always count on me. So tell me a little bit about how you interact with your patients, especially young patients who may not have a primary physician, both from a female and male standpoint, because that can be a very real issue. In MS clinics, you're being asked to do the neuro, but they're also wanting you to do the primary care.
Absolutely, absolutely. I have so many patients who I say, who's your primary care? You are. I'm like, not me. So, no, we talk about that. And again, luckily, I work within a large health network, and so I will try and coordinate them, both male and female, to get in with one of the primary care providers in our system. But I will not, of course, exclusively say that, but I will give them those resources. So again, we can all be in the same system and have better collaboration. They're able to see all the blood work I've already done. They know what medications, the medication list is up to date. Is it happening? Did someone not eat breakfast? I'm really nervous. But anyways, so yes, I really work on that. And if someone, if it's a female and they would prefer a female provider, then I'll talk to them about some folks for that. If it's a male, they seem to be a little less concerned, but we'll have you talk about that later, Jeffrey.
Do you find that the primary care physician, when they hear something going on with your patient, doesn't want to treat them and says, it's your MS? How do you handle that?
So many times, oh my gosh, because it's hard. As we all know, MS affects you from the top of your head to the bottom of your feet. And so many times patients get like, oh, well, I went in and saw my PCP about this, and they said it's just my MS. And so we tease it out, we talk about it, and we're like, I'm not really sure about that. So if it is, and if it's a PCP that's within our system, I may reach out to them myself and say like, hey, my goodness. Anyways, I will talk to them about that, and we will help to coordinate with that PCP, and I may reach out to them myself and say, hey, I'm pretty sure that this is not related to the multiple sclerosis. Can we work this up a little bit in another way? Yeah. Any other questions?
I'm going to keep asking questions because these are things I think are great. Talk a little bit about COVID as a potential comorbidity with MS.
Absolutely, absolutely. So, we are still seeing folks who are getting COVID now, and so I've had a lot of patients, they call in, and they will get, I'm so distracted by this, I apologize. So they will, they'll call in and they'll say, hey, I just tested positive for COVID. I'm due for my next injection or infusion or something like that. And so we may need to coordinate like, okay, well, let's maybe hold off on your infusion for a little bit. But then there's the people who are having the lingering symptoms, like the cough in this particular patient. So we look to really make sure that she's been into pulmonology to have that fully evaluated. Again, really continue to educate on the stopping smoking and going from there. And then, a lot of those patients can express cognitive issues. I may get them in with one of our neuropsychologists if we can't tease it out other ways. And then the fatigue component of it, just making sure that I've crossed all that whole list of what I work on, check their thyroid, making sure they're sleeping well, all those other things. And then we talk about if we've tried all of those things, they're staying physically active, they're eating a better diet, and they're still fatigued, we might talk about some of the medications we can to treat that as well.